Bilal. So my today's presentation is, some of you may have known me, who are in my corneal and refractive group, they know that I give lots of emphasis on keratoconus. This is one of the topic which you will automatically get in exam, one question or another. So it's very important that we cover each and every aspect of this topic. So, okay, Dr. Kaushik, it's not moving again.
You can answer and yes, it's moving. It's moving.
So basically, keratoconus is my emphasis will be to just give baseline, definition, signs and symptoms. More emphasis is on the important topic like role of pentacam, its diagnosis, its interpretation, treatment options like CXL. We will like do it in detail or more question and answer session. Challenges in cataract surgery in eyes with keratoconus, and if we have some time, we can go to corneal hydrops. So what is keratoconus? This is a corneal disorder, progressive thinning of central or paracentral stroma, which leads to protrusion of the cornea from the central or paracentral area, which manifests itself in the form of irregular stigmatism. Okay, so most of the cases, 8% of them are because and 92% are environmental factors. Is there any heredity? There is no fixed pattern, but if there is a family history of keratoconus, there are chances of having keratoconus 1 in 700 people. Right? So basic pathophysiology is there are great irregular. So some risk factors with keratoconus sensitive. So there association or systemic association, if to tell what are associations, it will be great. Otherwise, I will. So, risk factors are eye cupping, weakness, sleep apnea, floppy eyelid syndrome, retinitis pigmentosa. This can be associated with disorders like Marfan syndrome. Positive family history, there can be because of Down syndrome or hormonal changes. This is very important. Many people who are during pregnancy, cornea, they have some tendency to develop keratoconus and also hypothyroidism. Yes, these are the risk factors which are involved with keratoconus. So we will our initial part, please. We can come to the more important or more tricky parts. Graded in different ways. This is one latest. You can see there are four criteria for this ABCD criteria. A is anterior corneal curvature, B for posterior, C for thinnest pachymetry, and D is for best corrected visual acuity. Now, if you look carefully, you will see that stage 0 and 1, they are almost normal, like clinically. Both have 20/20 vision, and they will within normal limits. Then 46.5 in stage 1, it's 48. And I believe these 0 and 1 stages, these are the ones which are most tricky, both in clinical setup as well as in your. Like examiner shows you a case, asks you to examine the interior chamber. You don't have any kind of refraction in front of you so that you can have an idea that this may be keratoconus. So you look in the slit lamp and you don't find anything. This happened with me. So my suggestion is always make a slit and look at the cornea. You will find conclusion. So stage 0 and 1, these are the ones which are most tricky to be found. They have thin pachymetry though, so the only finding will be that. Stage 2, it has curvatures more than 48 up till 53. And if you have seen enough cases, then you will know that many cases which have corneal curvature more than 48, they may be normal. They may look normal. So that coupled with thin pachymetry, but more than 400, that is grade stage 2, and there will be some decrease in vision, 20/40 or 6/12. Stage 3 and stage 4 are very obvious. They have pachymetry more than 53, and stage 4 has more than 55. So this is the grading. You can memorize anyone, but grading of keratoconus is also very important. When we come to the next step, you will realize why it is so important. So how do people most present with rapidly changing their prescription of glasses. They have higher astigmatism, high myopia, especially in teenagers. So these days, this is a routine that whenever a teenager comes with rapidly deteriorating vision with astigmatism, we do pentacam keratoconus at early stages, but there can be other symptoms like difficulty in vision at night, halo glare, and sometimes it can be incidental finding just during workup for refractive procedures. This is so common, especially in our region where people don't even know they have keratoconus. So incidental finding is very common. And then there can be sudden deterioration of vision with pain, which is usually corneal hydrop. But before we go further, guys, every ectasia is keratoconus. You must be clear in mind some other disorders which you have to rule out after these keratoglobulus and pellucid macular degeneration. They are very clear. Like if you look at them, examine clinically, you will be able to see. But contact lens induced corneal warpage, this is so common and misdiagnosed. A person is wearing contact lenses for the long time. Refraction shows, K readings or auto-ref shows high myopia with astigmatism. Pentacam shows all the markers of all the markers of keratoconus, but this may not be. This can be only corneal warpage. So you must keep an eye on this thing. You wean them off the contact lenses, and sometimes all things become normal. So in addition to these contact lens induced corneal warpage and corneal ectasia post-refractive laser treatment, in most cases, when you do pentacam after laser treatment, if you just look at the pentacam, you won't be able to diagnose it as keratoconus or something else. So all the differential diagnosis is very important. And when you are asked in the exam, it is very important that you do tell that although this looks like corneal ectasia, don't jump to say this is keratoconus. You must keep in mind that this can be something other else. So diagnosis, basically, like everything, gold standard is slit lamp examination, external signs. All we have mentioned, keratoconus isolated. I again emphasize, don't get on keratoconus. Do look at other things as well, atrophy, retinitis pigmentosa, and all these things. But gold standard for the diagnosis, corneal topography and pachymetry, because these are the things that help you to diagnose keratoconus. Okay. So there are some signs which you have to look at. There are early signs like asymmetrical refractive error, there is scissor reflex on retinoscopy, inferior steepening and thinning and steepening of the cornea. All these are important because if this comes in the exam, examiner may ask you to elicit all these tests.
Madam, your voice is actually like getting like disturbed in between. Sometimes it is loud, sometimes it's not loud.
So, what let me try to mute it up and go.
Yes, ma'am.
Let me try that.
Yes, yes, ma'am.
Last time I did it work. So give me 1 minute.
Actually, ma'am, you are not audible now.
Okay.
Ma'am, sometimes it's clear, sometimes it's not clear.
Just give me a few minutes.
Okay, madam.
Okay. Is there echo?
Yes, ma'am, echo is happening.
So let me share this screen.
Madam, you can keep the a mute and reduce the volume. Like reduce the volume of one device on which you are not speaking to 0 or minimum.
Okay, let me.
Basically, you can reduce the volume of the laptop to 0 and keep it mute and talk on the mobile. I think that would work fine.
So now is it better?
Yes, ma'am. Perfect.
Okay, so let me go back. So where were we? Can you hear me now?
Yes, ma'am. Now it's a lot better. It's very
Okay.
clear.
Okay, so I will start from here. So we have seen, so I was saying that we must consider differential diagnosis when we are seeing a case of keratoconus, which is pellucid marginal degeneration, keratoglobulus, contact lens induced corneal warpage, and corneal ectasia post refractive laser treatment, right? And then for diagnosis, the gold standard is corneal topography, but we must remember to look for the external signs and slit lamp examination and pachymetry. So I was just saying there are some signs, early signs, asymmetrical refractive error, Vogt try, all these signs I have already said. And in late stage, there will be Munson sign, breaks in Bowman's layer, acute corneal hydrops, and stromal scarrings. You all know this. So let's move to the next one. So most important, once you have seen a case which has irregular astigmatism and you're suspecting keratoconus, you do look for the signs. Most of the time, you may not find any finding on clinical examination, or there will be some ambiguities. Then the gold standard is this keratoconus. Now, let me tell you a few things. This pentacam, sometimes the pentacam will be as clear as this one. This is a classic case of keratoconus, advanced keratoconus. So I'm sure there are some people who are very proficient in reading keratoconus, and there will be some who have some difficulty. So I will tell you how to read that in exam without missing it. So first step is, remember there are two parts. I'll just spend few minutes over here because this is the most important part. There are two parts. One is numerical values and other are these graphic values. Okay, so this is say curvature curve, this is pachymetry, this is anterior corneal curvature, this is posterior corneal curvature. So first step is you read any area, look at the color coded map. So you see any warm colors, red and these, that means there is something abnormal here. So in curvature curve, you see these things, you can see high values 53.4, even 60.8. In the corresponding area, you will find corneal thinning. Area of thinning is central and paracentral, so you can confidently say, okay, this looks like keratoconus. Okay, so this is anterior wall, posterior wall is showing red lines. You move to the next scan, you see these red lines, and you can confidently say, even a layman, even a resident can say this is a keratoconus. Okay, so but sometimes things cannot be as simple as they are here. Now, look at this one. This is a case of keratoconus. I'm telling you beforehand. Now, if such case comes, then there can be some problem. So let me tell you how to look at these things systematically so that you don't miss anything. First step is to look at this corneal front. You can leave corneal back. From corneal curve, you will look at the readings K1, K2, and K mean. These values normal, if they are less than 47.2, they are normal, usually, but there is no hard and fast rule. They are normal. 47.2 to 48.7, they are suspicious. And if it is more than 48.7, this is usually abnormal. I'm saying usually because there are sometimes cases where our curvatures can be remarkably high, but still there cannot be any keratoconus. So you see these things. In this case, you don't see any problem. You are looking at K maximum, that is 46.2. So far it looks okay to me. The other thing is astigmatism. If it is more than 2.5 diopters, you have to be suspicious that this can be keratoconus. Another criteria is that your subjective refraction and the astigmatism on this page, on this pentacam, it is differences more than 1 diopter, you have to be suspicious that there is some problem in the cornea. Same is for axis. Axis, difference of axis more than 10 degrees. That is all. That also shows that there can be keratoconus. There can be keratoconus. Okay. So first part, if I see in this scan, I don't find any problem except that no, I don't find in fact any problem in this. So I can say I don't find any problem. Now we go to this part. This is very important, pachymetry. This is more important than you can think. There are 3 parameters. Topmost is pachymetry at the center of pupil, then it is at the apex, and this is the thinnest point. Now look at these things. These values are low, cornea is thin, but how thin? Sometimes there can be normally thin cornea. So if the difference between, more important, these two, apex and the thinnest, if difference between these two is more than 10 microns, that is abnormal. In this case, we don't find any problem. We say this is within 10 microns, so this can be normal, although cornea is thin, right? So another thing you have to see is, you can see this X and Y, these are coordinates, location of the thinnest position. This thinnest cornea, look at the Y coordinate, this value should not be less than minus 0.50. In this case, this is minus 0.81. So far, the only clue I have been able to find is that the cornea is very thin. It's left 462, and its coordinate thinnest area is quite below paracentral area. So far I have been able to find this thing. Okay, can you understand so far? Any question? Okay. So then come to the pachymetry. You see these areas, yellow warm colors show that there is thinning, 465, 469. So in this case, we find these things. Now we look at the anterior and posterior walls. Before that, look at this corneal curvature. There is another finding. Can you see these data lines? These are, whenever you are reading pentacam corneal curvature, you just look at the central. More emphasis should be on central 5 to 6 millimeter area. This one, okay. So you see these lines, data lines. These lines should be in straight line, like this. And like this. If there is skewing of data, like these lines, they are skewed more than 22 degrees, this means this is irregular astigmatism. There is some problem in this, like in this eye. Similarly, you look for inferior superior disparity, like choose 1 point over here, 1 point over here, and see the difference. This is 46.2, this is 41.8. If the difference is more than 1.5 diopters, this is also abnormal. So in this scan, so far, we find 2 problems. Number 1, there is thin, cornea is thin. Its Y coordinate is less than below minus 0.50. And it has some skewing of data. Correct? Can you hear me?
Yes,
Dr. Kaushik?
Yes.
Okay. So
Yes,
okay, I was thinking like I'm talking like on my own. So if you have any questions so far, you can ask me anything you don't understand. Okay, so we'll move to the next one. So these are the elevations. Again, I would emphasize, just more important are this circle. They have drawn this circle. This central 5 to 6 millimeter is most important. Look at the values over here. Normal, these are basically, these values indicate the areas of elevations. If they are plus, they are elevation. If the value is less than, for normal cornea front wall, I'm talking about front wall, these values should be less than 13 millimeters, 12 millimeters. If it is 13 to 15, you find any number 13 to 15, that is suspicious. And if it is more than 15, it is definitely abnormal. So if we look at this eye, I don't find any problem again. This looks normal to me. Central area. Now, back wall values are slightly high, like that was 12. In this case, it should be less than 15. Sorry. So values should be less than 15 or less than 17 are normal. 18 to 20 are suspicious, and more than 20 are abnormal. So if we look here, in this eye, we see just C1 plus 20. So we are still not sure if it is keratoconus or not. Okay, so we move to, do not commit. Even if you think this is keratoconus, you move to the next chart, which is very important. This is where line Ambrosio ectasia scan. This is very important. So why is it important? Because this is without checking, sometimes you may find this page absolutely normal, and you analyze this one and you will find that there are some abnormalities into that. So let me explain in first for a few seconds. You have to basically look at this color coded thing. This is front wall, this is back wall. Okay, so you can say this is basically a 3D image of the cornea. And after creating a 3D image or artificial intelligence AI generated image, you analyze the cornea, you put a best fit sphere. Best fit sphere is, you can say, an ideal contact lens or ideal corneal surface. You put it on that imaginary and read any areas of elevation. Any areas of elevation above will manifest themselves in the form of elevations. Forget about that. If you just see red lines, immediately look at that thing, you will find that there are some areas of elevation like this here. So first is this, you look at front wall, this looks okay, but on the back wall you find some elevations. Now this one, this is its enhanced form. You can say that if some abnormalities have been missed on this scan, they will manifest more on this one. So you see these red lines, areas of elevations. Then third scan, this analyzes everything, anterior wall, posterior wall, pachymetry, and it gives the final data. So you see in this eye, posterior wall, you find this red point that shows that there is abnormality. This is outside the normal range. So in this page, when you find, in simple words, if you find these red lines, you directly look at that area, you will find higher numbers, plus 45, 37, and this will be abnormal. Now, before commenting on that, you must look at these D values. Okay, so D values are basically deviation values. Like everything, what is basically D values? They check anterior, posterior elevations of the normal population, their pachymetry. They created a data, and then this characterize that this one comes in the normal range. Anything outside this range is called abnormal. So these D values, they indicate different things. Okay, so DF is D front, means front wall abnormalities of front wall. DB is abnormalities of the back wall. DP is D pachymetry, means thinning. DT is the thinnest value. DA is thinnest displacement, the thing I told you on this point, displaced below the on Y coordinate. And final D is by taking into account all these things. So you can simply say, like you see abnormalities here, you look over here, you find these lines. So what is not the normal values? Every value should be less than 1.6, be it DF, DB, less than or final D value, less than 1.6 is normal. 1.6 to 2.6 is abnormal, mean you have to collaborate with other things. Like just yellow doesn't indicate it. You will find some clues in other scan as well. And if it is more than 2.6, this is definitely abnormal. So in this eye, although now we come back again, in this eye, this part looked okay, except that there is some thinning of the cornea. If you analyze deeply, you found some skewing of these lines. You didn't find any problem in anterior and posterior wall. If you leave it just here, you will say this is a normal case, just thin cornea. But when you analyze the other area, you will find elevations in the back wall, okay? And D values, and this shows this is a case of keratoconus. Obviously, you will collaborate it with your clinical findings. So this is the way. So pentacam is very important, gold standard, even in early cases, you can find that. Now, this is the other scan. If someone wants to try that, go ahead.
Ma'am, can you summarize the thing from beginning, because there are lots of data, lots of numericals. Just want to hear from that the numerical parts, and just as far as a revision.
Perfect. So this is next scan I had put it for that. First part is, before everything, I forgot to mention, you have to see if scan is absolutely, first thing you should comment is that if your QS value is okay or not. I can't move my cursor now. Anyways. So to summarize, first thing you look at these K values. Okay, so look at the K. Dr. Kaushik, I'm unable to move my cursor. Let me do. Okay. Just a minute. Dr. Kaushik, I don't know what happened. It has moved somewhere. My cursor has stopped.
Ma'am, you can stop the like you can just press on escape button and then it should be visible. Press on escape.
Okay.
ESC on the left upper side, I think it is there. Yes, it is the A is visible now.
Okay. Okay, so my cursor was not moving. So I will summarize. I won't touch much. I don't want to have any problem. So first look at the right, leftmost, topmost line. So I'm going to enumerate once again. First step is to look at the K values, K1, K2, and K mean. If these values are more than 47.2, you have to be suspicious, right? So in this eye, you can see values are normal, 42.7, 43.3, and 43. Number two, you have to look at astigmatism. Just below K mean, you can see astigmatism. If it is more than 2.5,
Ma'am,
this
may
is
I ask a
abnormal.
question, please?
Yes, please.
So these values are normal. So why are the readings showing in red in this scan, the 43.31?
Because this person has keratoconus. These values are normal. Not every what I'm trying to say is, not every keratoconus will have anterior wall abnormalities in the anterior wall. You won't necessarily find a cornea which has curvatures more than 47. Sometimes anterior curvatures are absolutely normal. In keratoconus, what happens? Basically, the ratio between an anterior and posterior wall, that is altered. Hence, you don't only rely on the K values, you study it in detail. What is pentacam? Pentacam is basically giving you detailed analysis of the cornea. Anterior wall, posterior wall, breaks in data lines, positioning of the pachymetry. So the sole purpose of pentacam is it can detect subclinical keratoconus or early keratoconus, which are not manifesting themselves in clinically.
Right.
Got my point?
Yeah. So this scan has like analyzed more things, and that's why it has put it in the red because of other
Yes,
things.
no,
Otherwise,
no,
it's
no, you don't.
normal. Yeah.
So just read. I told you that sometimes it will be very obvious in advance. That will be only in advanced case. More often, you will find this kind of cases where everything looks okay, but a little analysis, and you will find that there are some abnormalities. Like if your scan doesn't show any problem, then you can't say there is any problem. So, okay, so these values are normal. This person has normal front wall, but if you look at the this curvature OS, the top left curvature curve, you will see that data lines are skewed. Can you see?
Yes. Yes.
Then you look at the pachymetry scan, and you will find that the cornea shows warm colors, and in warm areas you will see that cornea is thin, right?
Right.
Now you come down on the again a numerical look at the third part where pachymetry is shown. 40, you see 481, 479, 472. They look normal. They are thin, but there is no problem. But when you look at the y coordinate in front of 472, you will find it is 0.89 minus 0.89 on the y coordinate, right?
Right.
So basically, you look at these things, K values. Then you look at this curvature curve, curvature scan. If you find skewing of data, that means there is some problem, but don't comment that this is normal or abnormal. Go to the right topmost scan. Look at the central 5 millimeters. Look for the elevations. Now, how much elevations I told you on the front wall? Can someone revise? Does someone remember?
10 to 15.
No, normal values are less than 13.
Less than 30.
Less than 13 are normal. 14 to 15 are suspicious, and more than 15 are abnormal.
Okay, ma'am.
Okay?
Okay, ma'am.
And right lower most, that is back wall. Back wall elevations are very important. More often than not, you will find there. So what are the levels of elevations over there? Normal is less than 17. 17 to 20, 18 to 20 is suspicious, mean you have to analyze, you have to be careful about that. And if it is more than 20, then there is definitely elevation over there. Okay?
Okay.
Clear so far?
Yes.
Ma'am, these data are minus. Minus
Minus
13
are area of depression, plus are areas of elevation.
Okay.
Look,
So
these are,
here it will be
yes.
then plus. It all are elevated.
Yes, they will be plus. Imagine there is a line, we draw a line somewhere. Hills of elevation, we will show this is above that line, that is plus. Those who are below that, they will be minus. They are
Okay.
areas of depression. So elevation, we are looking for ectasia. We are analyzing ectasia. So we have to look for ectasia, mean elevations. But normally cornea has some elevation, so we have told this normal. So but I'm saying again and again, don't look extreme periphery, because eye is like curved. You will find some area of depression. So most emphasis should be on central, this area. And
so
plus
ma'am,
value.
you said
Yes.
the normal value is minus 13 or plus 13?
Plus 13. Less than plus. Less
Okay,
than
fine. And the
13
posterior curvature
plus.
is plus 17.
Plus 17, less than plus 17 is normal, 18 to 20 is suspicious,
Yeah.
and more than plus 20 is definitely abnormal.
And
Okay.
ma'am, what about the y coordinate? You are saying y coordinate is not understood. What
Look,
is that?
y coordinate, look, draw a line, draw a cross in the center of the cornea, imaginary cross. Okay. Horizontal line is x coordinate, y, vertical line is y coordinate. So in keratoconus, imagine the pathology is that thinnest cornea is slightly central or paracentral, slightly inferiorly displaced. So when you look at the thinnest area, normal, if it is less than minus 0.5. So any line, any point on the y coordinate below 0 will be minus. Any point above will be plus. So if you find thinnest area, pachymetry, and see the location, and it is below minus 0.5, that means this is keratoconus. This can be keratoconus.
Okay. The y coordinate in the thinnest area.
Thinnest area, thinnest pachymetry. That third point, 472. It is showing, in this case, the only clue is the skewing of data and that thinnest area, that is it displaced inferiorly. Okay. So again, this looks, this is more
Excuse me,
like,
ma'am.
yes, yes. Yes.
Ma'am, can you please tell in pachymetry the difference between the apex and thinnest is how much? It should be more than 10 micrometers.
10.
Microns.
Less than 10. Less than 10. If it is more than 10
Less than 10 is
microns,
one. Okay.
less than 10 is acceptable. If it is more than 10, that this is significant. Okay.
Ma'am, in this case,
Okay,
the
ma'am,
y
thank you.
coordinate for
Yes, yes.
It's not visible. It's 0.0 minus
0.89. Minus 0.89.
Okay, minus 0.89. So it is normal minus less
No.
than minus 0.5.
It should be less than minus 0.50. It
Minus
should be, had it been minus 0.4, it would have been normal. Had it been maybe minus 0.3, it means it was close to the apex, but it is minus 0.89. It's below, it's quite displaced. Thinnest area is displaced inferiorly. And even if you look at pachymetry scan, got it? This is very important point. This is very, and sometimes the only thing you find is these little things, and they give you that, okay, this is abnormal cornea. Clear so far? So
Yes.
even if you say this looks normal, don't comment unless you have seen the other part. Again, first look at this like a layman. You see some yellow areas and you see plus 19. Again, in the second row, you see in the back walls plus 25 values. And in the final, it's not showing any abnormality, right? So
Yeah.
you analyze D values and you see that DT, which is the displacement, D is thinnest point is to DT means thinnest pachymetry, D value for thinnest pachymetry. That is outside normal, but not outright abnormal, 2.17. DA is displacement of thinnest pachymetry, that is also abnormal, but not, that is outside normal limit, but less than 2.6. And overall D value shows 2.01. This is basically subclinical keratoconus. So in this case, you will just wait, you will observe, or you can, if you want, you will say, I will do the series pentacam after 6 months and we'll see the progression of the disease. But this is subclinical keratoconus. Okay.
Ma'am, in the
Yes.
first sheet, there is
Mhm.
also anterior and posterior elevation map. In the first sheet, among
This
the
one?
four. Yeah. Among the four,
Yes.
there is anterior elevation map and posterior elevation map. But the next sheet, it is also the anterior elevation. What
Yes,
is
yes.
what is the
Let
difference
me,
between the first and second sheet?
you can say first sheet is less concise analysis, like this is the analysis of this patient only, this patient. Okay, I have taken the data of this patient and I have plotted it this way: anterior wall of this patient, posterior wall of this patient. This is by after comparing it with the normal
Okay.
data from the normal population, how much outside this person's
Okay.
values are compared to other people.
Okay.
And same is true for D values. So this person's readings are going outside normal values. So this person had, in fact, subclinical keratoconus. Let me tell you, this was like 38 years old man. The other scan is also of this man. This is his left eye. We did topo-guided PRK, excimer laser with CXL on this patient because his pentacam was stable for quite long time. And it was amazing result. But this is subclinical cataract, keratoconus.
Ma'am,
Okay.
in the first,
Excuse me, ma'am. Pardon my ignorance, but I don't understand where are we looking for D values?
Right. Actually, my cursor is not working, and I was afraid to move it. At the bottom of the screen, you see these. Yeah, on the right side, you see 5 values. These D value 2.01.
That was not seen earlier. Thank you, ma'am. Yeah.
Okay. No issues at all. Okay, so this is pentacam. So let me summarize again. Whenever you find a case, so I hope in exam you find something like this. You'll be able to tell methodically that K1, K2 are abnormal. Deep down, you know what is that. You see these warm colors. You see thin areas in that corresponding to that steep areas. You see the elevation in the anterior wall as well as in the posterior wall. Then you look at these data compared, you find these elevations and D values, abnormal D values, you say this is case of keratoconus. But I would like to collaborate my findings with my history and clinical examination. If the case is like this, you have to go slightly deeper analysis. It will take just few minutes. Look at the K values, look at the stigmatism, curvature curves, and then pachymetry. Pay attention to this pachymetry area, this area. This is very important, okay? Then most important, you will find elevations in the back wall. Even if you miss something here, go to the next scan and see these, don't ignore these red areas. If you find anything red, that means this person has data outside the normal limits and you can proceed accordingly. Okay, clear?
ma'am, keep one new, and we will try. Otherwise, there's so much of data. I think whether you told everything, you have to practice.
I think for Pentacam, I have a separate presentation in which you can arrange any day. I will show you Pentacams and all of you can try. Let's do that any day.
Yes, madam.
Thank you,
Please
ma'am.
send me a
So
date.
this one,
I'll
okay. So okay. So this is not my original. I have taken this picture from this. So can someone try here?
So I am trying, ma'am.
Yes.
You said actually this is not so clear, ma'am. I need your help. You said the first we have to see the quality of the scan. You mentioned something.
That
I
is
am not.
okay. That is okay.
Yeah. Okay. Yeah.
QS, that is okay.
Okay. And the K1 is what is written, ma'am? K1 actually not visible, ma'am.
Actually, even
still.
I can't see that. Just leave it. Okay. What we will do, I will, sorry. Look, it's on auto mode now. I will send you a document for Pentacam. I have this document made for that. I will send you first, give it a read, then we will do a class on Pentacam interpretation. Okay? If that's all
Okay.
right with you.
Okay.
Don't worry about that. That is a detailed topic. We can go on about Pentacam. For now, just remember these things.
So, ma'am, what do you say to see the K1 and K2? And
Yes.
the K1, if it is more than 47.2, we have
Yes.
to be careful. And in astigmatism, if it is more than 2.5, and
Yes.
in thickness, you said if the difference between the thinnest and what you
Thinnest,
say?
thinnest
and
at the
thickest.
apex,
And
and the thinnest pachymetry. There
okay,
can be
and
difference.
if
Thinnest
it is
at the
more than
apex,
yeah
10.
at the apex and at the thinnest area, if it is more than 10 micron, and
Yes.
the y coordinate, if it is less than minus 0.5, it is important.
Yes.
And
Below
in
0.
sorry, minus 0.0 minus point
Fine.
minus 0.5. Okay. And in anterior curvature, we will see is there any skew deviations? And
Of the data lines. Of the data line, more than 22 degrees are significant.
Yes, ma'am. How the assumption of 22 degrees, like assuming, no? I think there is nothing perfect things to calculate it. It's whether it is 22 or
No, you
something.
just are you asking
Assume.
how to know it is 20 or 22? No, you just
Yeah.
see it and you can see this is more than 22 degrees. Just guess it.
Okay. And
Okay, because you have so many
what you
other things.
said that
Anterior wall.
you have you said any numerical data here in anterior curvature map? Any numerical
Yes.
data, ma'am? The difference I
Elevation.
have
You have
forgotten.
to look for elevation points. So less than 13 is normal.
Yeah.
13 to 15 is suspicious.
Not
More
elevation.
than 15 plus.
I'm talking about. No, I'm talking about that curvature map, ma'am. Axial curvature map.
Look, in keratoconus, what happens? There is inferior steepening of the cornea. Is it so? Abnormally.
Yes, ma'am.
Excessive protrusion of cornea.
Yes.
You remember this pathology? So on Pentacam, you have to look for inferior superior disparity. You choose two points on that circle, in one at inferior point, one at superior point, and calculate the disparity. If it is more than 1.5 diopters, that is significant. Mean inferior is more protrude. Sometimes, look, there can be some pathologies where there is superior inferior disparity as well. Mean superior is more ectatic. That value is 2.5 diopters. Okay.
Here, ma'am. What is the actually? It is, I think, in one axis I can see 42.3, and other the lower point is 43.1. So difference is not that much. But
so
here
it's all right. So you basically, it's all right, but you're seeing skewing of data. You made a mental note that okay, there is some irregularity here. Then you go for those lines, anterior wall and posterior wall. Okay, elevation. And then you see the color code. Just all you have to do is just look at the color code. Anything you see warm color, simply look at that point. And then look at the D values, and that will be. Okay.
Ma'am, got it little
So
bit.
remember, I repeat, not every case is keratoconus. So you have to analyze pentacam according to that. So this is the case of pellucid marginal degeneration. Why am I saying that? Everything will be like that, but your thinning is, oh, my cursor is working, great. So this area, you see elevations here. They are slightly inferiorly displaced. You can't say this is, if you find a case like this, you will say that this is corneal ectatic disorder. You are not sure this is keratoconus or pellucid marginal degeneration or anything, you will collaborate it with your clinical findings. Okay. So now we go to the treatment part. Treatment, because we have so much to cover. So treatment, there are three aims for the treatment. Basically, you want to halt the progression of keratoconus, that is CXL. Again, you have to see, you have to keep in mind the age of the patient. Younger patient don't have, we will do CXL, but we will discuss in detail. Second part is to treat the associated ocular conditions. If there is atrophy, VKC, retinitis pigmentosa, obviously you can't treat that, but you have to mention that I will look for other problems. Then first part is to improve vision. There are various ways you can use glasses, hard or RGP lenses, custom designed contact lenses. You all know that scleral lenses, piggyback lens, which has hard lens over soft lens, then hybrid lenses, which has RGP in the center and soft contact lens in the periphery, and PROS. This is important. I would like you to remember this thing. PROS is prosthetic replacement of the ocular surface. This technology can be used in any eye that has distorted ocular surface, be it stem cell deficiency or like in keratoconus. So what it does, this is a prosthetic device. Can you see this device? This is placed on the cornea. It basically vaults over the cornea, and there is fluid space between that. That fluid provides hydration to the cornea, and that outer surface that provides it works as artificial ocular surface. So it gives time for the epithelium to heal, or the front surface provides the optimal new ocular surface. So PROS, you must know this. One of the methods is prosthetic replacement of the ocular surface, right? So corneal cross-linkage. I would like you to respond to these questions. So CXL is corneal cross-linkage. First principle, let me tell you, principle is that we basically soak up the cornea with 0.1% riboflavin, which is used as photosensitizer. And then you apply UVA rays for about 30 minutes to stiffen up the cornea. So what basically does UVA rays on the riboflavin, they trigger oxidation reaction, which makes covalent bonds between the collagen fibrils, right? So this is the principle, this is occurring. So as aging occurs, all this process, that oxidation reaction happens naturally in the cornea. So there is naturally, you can say, naturally CXL is happening in your eye. So if the person is above 40 and you are given a scenario that this is the case, first time diagnosis, you must say that since a person is above 40, the cornea is stiffening on its own, so we don't need to do CXL unless we document the progression. So my question is, why we use riboflavin as photosensitizer? Can anyone reply? Because anything we want to put in the eye, that should be safe systemically if it gets absorbed. Secondly, whenever you're applying UVA rays on any kind of rays on the eye, there is a danger to damage the endothelium. So riboflavin is chosen because its excitation absorption peak is 370 nanometers, which is safe for the eye. Okay. What are the contraindications for CXL? Can anyone tell, please? Are there any contraindications for CXL?
In cornea,
Yes.
like less than
400 microns.
400.
Why? So if there is cornea is less than 400 microns, what will you do? You won't do CXL, or can we do something about that?
Ma'am, I have read hypotonic CXL.
Yes. That is basically, look, if cornea is very thin, it means whatever mean we use, there is danger that rays will reach the endothelium. So number one, we will discuss later on, there are two techniques, epithelium on or off. You keep the epithelium on so that there is more barrier. Number two, we can use hypo or smaller riboflavin. What will that do? That will swell up the cornea and less rays will reach the endothelium. Other contraindications, there are previous herpetic infections, current infection, opacification or scarring. Like a person has high drops and there is scarring, this is contraindication for that. History of poor epithelial healing, severe dry eyes, autoimmune diseases. All these are contraindications. Now I will give you a few minutes for next question is we are going to do epi on or off. Which one is better? The standard procedure, conventional method is epithelium off procedure, which is called Dresden protocol because this is an hospital in Germany. They created this protocol. In this, we use 0.1% riboflavin. We instill the drop. We first debride the epithelium, 8 to 9 millimeters. We instill drops of riboflavin for about half an hour at 5 minutes interval. After that, we expose the cornea with UVA rays for 30 minutes. This is epi-off. So as we said, if the cornea, so what are the difference? And sometimes we can do with epi-on. So which one is, I have just tried to compare that. Epi-off is more effective. These are all studies show that epi-on, that is 1/5 less effective compared to epi-off. Epi-off is not suitable for thin cornea. We have just discussed that it is painful because epithelium is removed. It's just like sorry. Sorry. And we need contact lens for 5 days. And in epi-on, advantages you can do it on less on thin cornea. Something is better than nothing. Although I have done many cases with epi-on, results are very good, but still data needs to be accumulated. They are better for thin cornea. There is less pain, less subepithelial haze. So you can decide epi-on or off, but epi-off is still preferable method. Then there are some surgical treatment, intrastromal corneal rings, ring segments, corneal allogenic ring segments, deep anterior lamellar keratoplasty, penetrating keratoplasty, and then there are some non-FDA approved treatment, like I said, that in that eye we did combined excimer laser with CXL, very selective cases, not conventional PRK. You need to have contora vision, topolizer, then you can do that and you can achieve good results with that. Okay. So this is very important topic, cataract surgery in keratoconus. I will try to finish it quickly. Cataract surgery in keratoconus is frankly the most thankless job in the world because patient will never be happy. But if a person develops cataract, you have to do something about that. So first step is to console the patient, tell that you are doing actually a favor to the person by doing the cataract surgery. However, we can do some things to achieve the best results. So first stage, do not assume that person knows that he or she has keratoconus. So first ask the history. Is he or she a known case of keratoconus? Did they have any CXL? Did they have any excimer procedures? Sometimes I said post excimer laser ectasia, they look almost similar to keratoconus. Treatment will be same, but still you have to ask that. Then there are ocular associations. Look for systemic problems, any connective tissue disorders. Look for zonular dehiscence, dilated fundoscopy to see for retinitis pigmentosa and visual outcome, and zonular dehiscence, and be prepared for that with CTR and everything. The biggest challenge is biometry. Then formula, choosing the right IOL, monofocal or multifocal, refractive surprises, how to treat that, and giving some realistic expectations. So can I ask a question? So how will you do biometry? What is the best way to do biometry in patient of keratoconus?
By
best is
tomography?
No, first, yes.
Immersion tech.
Okay. So first step is biometry. The biggest problem in biometry is abnormal K readings. You can take axial length. There is no issue with that. But basically, biggest value we have just studied, there are disparities between where anterior walls are normal, posterior walls showing abnormality, right, in pentacam. And most formulas use anterior and posterior wall ratio to calculate that. So in keratoconus, that ratio is disturbed. So we get abnormal K values. So unpredictable K values are the biggest reason. There are some other reasons like irregular tear film, difficulty in focusing. Patient is not focusing on the target. Patient is looking peripherally. So you are basically taking inaccurate K values. Then there is abrupt steepening from center to the periphery. We have just discussed that this gives falsely high K values. When there are falsely high K values, IUL power will be low and patient will have hyperopic shift. This is very common. And finally, front to back corneal curvature assumed by many formula is altered. So the biggest issue in keratometry is K value. So now you can tell. How will you do values, get K values? Sorry, I interrupted. So anyone who was telling me?
Corneal tomography.
Mhm.
We take it from
Tomography.
pentacam readings.
Sorry, I can't hear you.
We do corroborate with the pentacam readings.
Yes,
and
first
then
is if you have IUL master, use that. But not everyone has IUL master. We use pentacam K values. Now, this is very important. Someone asked me which K values to choose. Most formulas want ask for K1 and K2, but you just have to see one thing. I told you that significance of Y coordinate. You must identify that what is the K reading that is coming in the pupillary area. If your K maximum is coming in the pupillary area, then you have to use that value as well. Otherwise, simply pentacam, by doing pentacam, you can use K1 and K2 values, and that will give you can put it into any formula you want and you can use that. Okay. So in XLN, there is not a big issue. You can use either your conventional A scan, but there are some OCTs which have this feature. They can measure the axial length as well. So we use IUL master, or we use K values from pentacam, and you take axial length. Formulas, I have told you, you can use the modern formula. That's our K2 formula, Barrett universal formula, and do not use multifocal IULs. Can anyone tell why? Why we can't use multifocal IUL?
It will cause glare effect.
Yes, it causes glare because all multifocal IULs, they have those concentric lines on that. In keratoconus, already there are lots of aberrations. So if you use multifocal IUL, that will cause intractable distortions and patient will be miserable. However, you can use monofocal toric IUL. Despite doing everything, results may not be very good. There can be refractive surprises. Be prepared for that. Aimed refractive error is myopia with some astigmatism because patient is used to living with that. But usually we may get hyperopic shift. So we have to, by taking all those measures, we can try, but we cannot promise that. If there is residual refractive error, that can be corrected with glasses or contact lenses because most of them are already using. Remember, excimer procedures are contraindicated in in keratoconus. Okay. Clear so far? So now I'm going to this last topic. This is very important. In fact, last time I asked this question in my group and I was not very satisfied. This is corneal hydrops. I would like that some of you tells me first what is their treatment plan, and then I will elaborate. So corneal hydrops is basically aqueous humor enters the corneal stroma due to breaks in descemet membrane, which leads to localized stromal epithelial edema and sometimes diffuse edema. So if you find a case, if you're shown this picture in exam, and I ask you, what is the treatment for corneal hydrops? How will you investigate, and what treatment you will give?
First,
Anyone?
I'm taking, ma'am.
Yes, yes.
First, I will assess the visual acuity of the patient. Then I will do an ASOCT to see the extent of DM tear. And
Good.
in the picture, I am seeing the hydrops involves more than half, almost subtotal corneal edema has been there. So here there are options like desmetopexy with compression suture. As there is extensive involvement, I will go for compression suture with desmetopexy.
Good.
These are
So,
surgical things. First, I will say the conservative, like hypertonic saline drop,
yes.
hypersol 4
Mhm.
times, and hypersol 6 ointment at night, along with copious lubricants. And if there is
Good.
no epithelial defect, I will add topical steroid. And if there is pain, I
Perfect.
will add cycloplegic.
Very good. So I'm glad that you mentioned the use of that OCT. So let me elaborate that, how we do that. So remember, again, anything, any pathology that can cause a break in your desmus membrane, that can cause corneal hydrops. Again, don't assume that this is because of keratoconus, okay? So you have to look at the other eye for history, and examination of other eye is very important. Data shows that only 2.4 to 3% in cases, hydrops incidences in just 2.4 to 3% in keratoconus, 6% to 11.5% in pellucid marginal degeneration, 11% in cases of globus, and it has been very rarely reported in Terrien's marginal degeneration, post-refractive surgery ectasia, and post-keratoplasty ectasia as well. So you have to find out the pathology in the other eye. Good. So how to investigate? You will go systematically. You take history, you try to find out the cause. Now, main is obviously slit lamp examination of the affected eye, of the other eye. Now, what do we want to find in the slit lamp examination? We want to find out pathology. Number two, we want to grade edema and corneal clarity. And we can perform sedal tests. Now, all these things are important because your treatment will change. Like just doctor said that he will go for compression sutures, because every treatment cannot be treated with just hyperosmotic solutions, etc. So if sedal test is positive, that means the fluid is coming from, there is a passage between aqueous humor to the cornea, and it is continuously oozing. So simple measures won't work. So you have to give anti-glaucoma treatment, and you have to find out where exact pathology is. So find out, do slit lamp examination, and then use the modern technology to find out whichever you have. So we will discuss them one by one. So first, you look at the cornea and you do the grading of corneal edema, or you can say, I will grade the clarity of cornea. Corneal edema, if maximum diameter is 3 millimeters, it is called grade 1. 3 to 5, it is grade 2. And if it is more than 5 millimeters, it's grade 3. The one I showed, it is definitely grade 3. Clarity of cornea, we can grade it in 4 categories. Grade 4 being the clearest cornea. There is no problem. Grade 0, no view. Grade 1 is obscured iris details. 2 is obscured pupil lens details, and grade 3 is just mild haze. Okay, so you grade corneal edema and clarity, because when you document that, you will be able to see the progression of the disease properly on the paper. Now, first is we should use ultrasound biomicroscopy. This is very important because all these technologies are there to help us. So what they do, they will be able to tell you the area and extent of desmus membrane tear. You can see here. Intrastromal clefts under the area of edema. If there is any communication with the anterior chamber, you can actually see that. And you can also measure corneal thickness, because when you do repeated biomicroscopy, you can tell the patient how is it improving. So one option is ultrasound. Almost everyone has these things. But if you have anterior segment OCT, nothing like that. This gives you one advantage is it is non-contact. You don't have to touch the eye. It will document corneal thickness and reduction, but it will exactly tell you tear dimension, configuration of the edges, intrastromal clefts, and even depth of desmus membrane detachment. Look here, desmus membrane is falling down. So you can plan your treatment accordingly. So if you have technology, do use that. There is another technology just for academic purpose. Honestly, I have never done that, but confocal microscopy, this shows you epithelial and stromal edema. But the main advantage is that if you see unusual stromal cells like this with large speckled cell bodies and branching processes, they say that this is marker for development of neovascularization. This is just for academic purpose, but if you have slit lamp and OCT, you are good to go. So you document the pathology, you find out the extent, and then you plan your treatment. So management, we can say it's conservative management. We have to start it anyways. Hyperosmotic agents, topical steroids, cycloplegia, everything, bandage, contact lens, all these things. Now, based on your pathology, you have decided that I will go for this either conservative management or surgical. So this picture is very good graph. It shows how to manage that. So conservative management, if you go for surgical management, your decision will be based on your finding the OCT, right? So if you think that there is desmus membrane posterior stromal tear and we can reoppose it, so we have few options. You can use intracameral air or gas, right? Which gases we use? Can someone tell? And concentration?
C3 effect 14% and
Yes,
SF6
20%.
20%.
Good. So either gas or air. Air resolves quickly, gas lasts longer, so you can decide accordingly. Number two, compression sutures. Okay, so what are compression sutures? Honestly, I have never used that, so I was very curious. So compression sutures are like this. Have a look. This is your eye. This shows edema. These are desmas, tear. Now, what they do first, they inject a gas bubble so that there is some you're providing basically protection. You don't touch accidentally lens and iris. Then they pass vertically sutures like this, and you full thickness, and you repair it, the desmas membrane, because this tear may not be you may not be easy, always it may not be always possible to reoppose it with gas, so you can do compression sutures. Other option is you can do thermokeratoplasty. How it is done? Now again, come to this picture. If there is large area of edema and it is not settling down, what you do, you remove all the epithelium over that area, and then that cautery we have we gently, very light, we apply it, small burns on that area, or all the area of edema. It basically causes shrinkage of collagen. Obviously there will be scar formation, so it comes in the later stage, but one option is thermokeratoplasty, depending upon the case. And we can do plasma injection. It is seen that plasma, by injecting plasma, basically this plasma, it has number one, it provides mechanical support over there to the tear. Also, it has growth factors which promote the migration and regeneration of endothelial cells. So sometimes we can do plasma injections as well. Okay, so if you want to seal the desma membranes, we have these options. If we think that desma membrane is very badly ruptured and we cannot reoppose it, so we will think about replacement of effective desmas membrane, deep desma stripping, anterior endothelial keratoplasty, mini desma membrane endothelial keratoplasty. What is it? This, let me tell. This is your, let's say, this is your desmas. There is rupture over here. Rest of the endothelium is okay. What you do, you can remove a small patch of desmas membrane and you can inject a new small patch. This will be called, and you will reoppose it with the gas. This will be called mini desma membrane endothelial keratoplasty, or full DMEK. Sometimes if there is lost case and there is stromal scarring, that we will replace the edematous stroma. Okay, so this is basically high drops. Although it looks simple, but corneal high drops, for exam point of view, and even from general, since we have technology, we can't say that we will just wait for, we will put glycerol drops and we will wait that. Obviously, if you don't have any other option, then you can use that. But if you have technology, you have to do all these things and you must know them clinically. Okay, so despite that, there will be complications of acute corneal high drops, scarring, infection, raised IOP due to steroids, and there can be perforation. Okay, so that's all. If you have any question, do let me know.
Ma'am,
Ma'am, can you
yeah, please.
Yes.
ma'am, can you please tell about the plasma injection? Can you please repeat that? How
Okay.
it affects the endothelium?
So sometimes, yes, plasma injection, basically you take the plasma centrifuge that, and you inject 0.3 ml of that, 0.1 to 0.3 ml of that into the interior chamber. Okay, what does this plasma do? One, it will 0.3 ml of plasma you inject into the anterior chamber. It will give some support, basically mechanical support. It will also give that, but basically plasma has what? Growth factors. So these growth factors, they will promote migration and sometimes regeneration of endothelial cells. So if all hopes are gone and you think that this is not responding to any treatment, you can try plasma injection. Okay.
Okay, thank you, ma'am. Yes, ma'am. Thank you.
Anyone else?
Ma'am, in case of high drops management, is there any
Yes.
step ladder technique? Like first we will do the desmetopexy with air, or if not clear, then pneumatic desmotopexy. If not clear, then compression suture desmotopexy. Is there any stepwise technique, or we have to decide on the presence of finding?
You can look, that totally depends on you. Obviously, in any treatment, before you embark on some surgical treatment, you have to go for conservative treatment. You'd give that. However, if your OCT shows that desmoid is totally displaced, like there is no hope for that, then you have to go for surgical. You can plan that. So start conservative treatment, uh, put air or gas. That is least we can do, and do see the response. If you don't see any improvement, then you can go for surgical. So answer to your question is no, it depends on your choice. But if you're going for any surgical intervention, it's better to go for some conservative management. But if you see that there is, if you are absolutely sure that there is no hope for reapposition, or after putting gas, you do the OCT again and you see that this is still displaced, then you can go for compression sutures directly.
Okay. What picture you shown and hydrops, is it secondary to keratoconus or keratoglobus, ma'am? It involves almost the total cornea.
I have taken it from just internet, so I'm not sure about that. So this was just to like start that. This can be, you can get this picture. This looks more like retoglobus to me, honestly speaking, because whole cornea is like globular in shape. So for that, you have to look at the other eye. You can see the pathology over there. Hence, I said always look at the other eye. And in the exam, from exam point of view, give your answer systematically so that you don't miss anything. Okay.
But ma'am, can keratoconus have such a desmoidocele? I mean, can it involve the entire cornea?
It's very rare. It's very rare.
Thank you.
But if it's advanced keratoconus, very high, curvature, like the first picture I showed you, 60.8, it had that person developed corneal hydrops, but not like this, honestly speaking. But it depends on how much break there is. So any amount of aqueous that depends how much fragmentation of desmoid occurred. So it can happen, but this can be anything. Not very common. Usually it's small, localized.
Ma'am, the criteria which you told for keratoconus in pentacam, supposing we don't have a pentacam, we're given some op scan or placido disc system topography. So what are the basic criteria we need to say, because there is no elevation in that, no ma'am?
Look, op scan. Op scan, for quite some time I used to do use op scan for refractive procedures. So whatever limited data you have to work with that. In the more chance in that, you will be able to find more obvious one. Like if you go systematically, you will be able to see these corneal curvatures. If there is no back wall elevation available, then you will miss many things. So always go for, so then you have to, if you have to sync your findings with the clinical finding. Like in a keratoconus patient, if your op scan looks normal, but you check the patient, even number is small, like -3 with 1.50 cylinder, it looks okay, but it's not giving 20/20 correction. Or you are look at the cornea, you find some abnormal steeping, or even if you don't find that, if vision is not full, then you have to wait. You will just observe, and you will do series of scan. So best way is to go for the next technology. So even op scan has its limitations. It doesn't treat posterior walls.
Thank you, ma'am.
Okay. So is it enough? I think. Any other question? If you want to revise pentacams, we can do a class. I will discuss with Dr. Kaushik. I did make a presentation about that. I will send a document first to all of you. I will send it to Dr. Kaushik because I'm not on Telegram. I cannot use that because of limitation. Read that document first. I have like highlighted all the areas and I have written all the criteria. You read that document again and again and practice that with your pentacam in front of you. One, I have given the picture. Once you have done that, then we will do a class in which I will show you many pentacams and you can do practice one by one. We will do at least 10 to 11. Yes.
Ma'am, can you say again regarding the pros?
Okay.
What
So
actually it is?
PROS is prosthetic replacement of ocular surface. Okay. This is one of the modality to treat, to give optimal vision in even keratoconus. But this is not specifically used for keratoconus. This can be used for any condition which has ocular surface abnormalities. So PROS is basically a prosthetic device, small prosthetic device. Can you see here? This just vaults over the cornea. Okay, it is not actually touching the cornea. There is space between cornea and this device, and there is fluid in between this normal tears or fluid. What it does, this fluid, this hydrates the cornea. Your cornea is protected from your blinking and any kind of aberration. So if there is any kind of epithelial abnormality, that can be healed. Plus this surface, this acts as your new cornea now. So you can use PROS device. Okay, so it's sandstone.
It's made of which material, ma'am? It's like contact lens. It's actually I'm not there.
I have to check that. I don't know. It wasn't mentioned, but it is small device, prosthetic device. So we will check. I think it will be made up of collagen. So we will check it. I'll check it.
It is like a contact lens only.
It acts
Okay,
like
okay.
cornea. It's
Like
a
a
small
contact
device.
lens. But it is very costly.
What is it made of? What is it
I don't remember the year, but it is transparent material. The material is transparent and it is like a contact lens.
awfully expensive, right? We don't have it
And
here,
they make
so I
it.
have
They
never
make it. I
seen
think
that.
they make it custom made. Like you have to give the things and then like it.
Okay, but for academic purposes, you must know this technology. Okay, so this is a new technology. You need to know it academically. Okay, I think we are done. I'll send the document
Yes,
to
ma'am.
Dr. Koshik.
Yes, ma'am. Please send
Read
me.
that
I'll send it
document.
to the Telegram group and also let us know a class, know a time. Then we can arrange a pentagram class because that will be very helpful.
Yes, but then we
For
will need
the
volunteers, Dr. Koshik. But for that, we will need volunteers. I have
yes.
actually,
We will need
we
at
will
least
need
10 volunteers for that.
who will come one by one. No need to worry. I'll correct them. If you read that document, I have made it with so much like effort for my understanding, because whenever I have any confusion, I've just opened that and I just revise that. If you read that, I assure you, you will be able to read Pentacam in just 2 to 3 minutes. So I will send the document to Dr. Koshik and he will give to you. Read that. When you are done, all of you, then we will arrange a class. And I'll show you Pentacam, then we can do that. Okay?
Yes, ma'am. Thank you, ma'am.
Thank you. Thank you so much.
Thank you. Good
for
day.
your
Good day.
patience.
Thank you so much for the presentation.
Thank you, ma'am.
Okay.